next lecture is on fecal cal protectin when and why Dr. Malathi S. Dr. Malathi S. is the senior most consultant pediatric gastroenterologist of India, and she is a consultant at MGM Healthcare, Rainbow Children's Hospital, Kanji Kamakoti Child Trust Hospital, Chennai. And she has more than 70 publications to her credit, and she was a past president of ISPGHAN. And over to Dr. Malathi S. Madam, please.
Evening. I wish to thank Dr. John Mathai and Dr. Naresh for giving me this opportunity. My topic is fecal calprotectin, when and why. The incidence of pediatric IBD is increasing all over the world. However, it is definitely less than functional GI disorders. Fecal calprotectin is a non-invasive fecal marker introduced with a sole aim or with two objectives. One, to identify children who may not require endoscopy and who are actually suffering from functional GI disease, but may share some common symptoms with inflammatory bowel disease, and in the monitoring and follow-up of children with inflammatory bowel disease. So fecal calprotectin, when and why is my topic. I think Dr. John Mathai and Dr. Naresh have assumed that we all know about what and where about fecal calprotectin. But I thought I would just share with you some points about what and where of fecal calprotectin before we go to the when and the why. What is fecal calprotectin? Calprotectin is a calcium and zinc binding protein of the S100 calgranulin family. It is a 36.5 kDa heterodimer composed of one light chain, which you can see in this cartoon, and two heavy chain calcium binding chains with zinc binding consequences. The green spheres are the calcium ions. So you can, this is the cartoon of the calprotectin. So what does calprotectin do? It is antibacterial. It also has an apoptosis inducer activity. It is a chemotactic activator. It participates in leukocyte interactions with the endothelium. It initiates cellular adhesions leading to the recruitment of leukocytes into the inflamed intestinal tissue, showing that it is from the leukocytes and therefore all this activity. So you know what is calprotectin. Now where is this fecal calprotectin formed? Calprotectin is mainly from neutrophils and constitutes 30 to 60% of the cytosolic protein. It is also from monocytes. Neutrophils and monocytes form the main source of fecal calprotectin, and it is also from macrophages. CP can also be produced by the bone marrow cells, by squamous epithelium, some mucous epithelial cells, microvascular endothelial cells, fibroblasts, all as a result of activation. So wherever there is inflammation or infection, these cells are present, and therefore you will get calprotectin there. So it usually correlates to the severity of inflammation and infection. So where is calprotectin isolated from? It can be isolated in any body fluid where there is underlying infection or inflammation. In GI disease, it is the mucosal influx of these cells, these calprotectin producing cells, through the mucosa, and therefore you get the fecal calprotectin in the lumen, and it's isolated from the feces, and therefore it is called as fecal calprotectin. Calprotectin is highly resistant to degradation by intestinal pancreatic secretions, intestinal proteases, and bacterial degradation, and is stable in feces at room temperature for at least a week. And this is a big advantage. So whatever calprotectin comes into the lumen, it is not degraded, and it is also stable outside the body. And even a sample of 5 grams is sufficient, though most of the tests we use more. So you know what is calprotectin, you know where calprotectin is formed. So where was fecal calprotectin used in GI disease? Where is it used? So till 2010 and all, it was a really very important role in the evaluation and monitoring of IBD since 2000. And we were all so excited about it because such a non-invasive test. And the concentration in the stool correlates with the intensity of neutrophil infiltration of the intestinal mucosa and severity of inflammation. No one can deny it is non-invasive, it is simple, it is acceptable, child-friendly, relatively cheap compared to endoscopy, and avoids unnecessary procedures, anesthesia, etc. An elevated fecal calprotectin level is usually taken as more than 50 microgram per gram, and it was shown in the earlier studies. Probably these were small studies, and it showed a sensitivity of 93% sensitivity and 94% specificity. However, you will see later that in the pooled sample data, specificity is much lower. So what does it do? It definitely does not differentiate other causes of intestinal infection or inflammation like in intestinal TB and from Crohn's disease. The type of IBD, whether it's CD or UC, it cannot differentiate. It cannot differentiate the location of the disease, whether small or large bowel. Then what does it do? It helps to definitely differentiate between the non-inflammatory conditions like IBS, which is a subtype of functional GI disorder from IBD. It also helps to identify the intestinal involvement in those children who present solely with extraintestinal manifestations of IBD. So definitely it is a use. Several papers came, and one of the early papers in 2007 by Fagerberg showed that it is a quantitative inflammatory marker. It can be used in IBD, and it correlates very well to the macroscopic extent and severity and also the microscopic extent and severity. When the children had IBD symptoms, they were symptomatic. The FC was very high, 392 microgram per gram. When a cutoff was taken as more than 50, 392 was very high. Then the asymptomatic IBD patients had only 32.9 microgram per gram. But of the asymptomatic children, when they had complete microscopic remission as seen in 56%, the median FC was 9.9 microgram per gram, showing that the higher they are, it may indicate symptomatic IBD, and when they are in remission, the FC falls. So what was the conclusion of this study? That fecal calprotectin can be used as a surrogate marker for estimation of colonic inflammation in IBD. Normalized FC concentration seems to indicate mucosal healing, and FC is simple to obtain and facilitates objective assessment and monitoring of IBD activity. This was where it was used in that time. There was the best study probably, and one of the elegant studies which was published in BMJ in 2010. Both the authors were pediatric gastroenterologists. This was probably one of the first meta-analysis of fecal calprotectin for screening of patients suspected IBD and see whether it would reduce the number of unnecessary endoscopies. So what was the aim? They evaluated whether when you do FC before procedure and then do the procedure, whether by doing these, we could decrease the number of endoscopies. Analysis of 13 prospective studies, out of them 7 were in children and teenagers. IBD was confirmed in this group in 61%. Majority used more than 550 microgram per gram as cutoff, and FCP used in 371 of B group. So FCP was studied, and the sensitivity was 0.92, but the specificity was 0.76. The post-test probability, that is, those who had the FC done and the endoscopy, they found that if you had an abnormal FC, you increased the probability to 86%, but whereas a normal result reduces the probability to 15%. So the final statements was fecal calprotectin could reduce the number requiring endoscopy by 35%. And this was a great breakthrough in the study in the work of pediatric IBD. Testing for FC is a useful screening tool for identifying patients who are more likely to need endoscopy for suspected IBD. So if you do this as a screening and you will be able to unnecessarily remove all those children who go through endoscopy. So they suggested a new pathway in 2010 where they said children suspected inflammatory bowel disease. So if you have some features of inflammatory bowel disease, screen them first with fecal calprotectin. And if the fecal calprotectin is high, then you do an urgent endoscopy and start them for treatment if necessary. If it's not suggested, then you plan other investigations. But if fecal calprotectin is normal or very low, then you do not do colonoscopy. So it was a very simple algorithm. And in 2016, another meta-analysis came that just don't look at fecal calprotectin alone in the sensitivity, specificity, and to identify these children. Holtzman did a very good meta-analysis and published this, where he looked into 19 studies, a total of 2,806 children, and he found, what did he find? He found that symptoms, abdominal pain, diarrhea, rectal bleeding, and weight loss was not very sensitive. Only 25% of the children have these symptoms, as we all know. But in the blood test, two factors, namely C-reactive protein and serum albumin, these were the best, but the best non-invasive fecal marker was fecal calprotectin, which was done in 10 studies with a high sensitivity, but a specificity of only 0.65 in the pooled. So the suggestion was, if you use a combo of a fecal calprotectin or albumin or hemoglobin or ESR, the pooled sensitivity could be better. And so the final conclusion in that study was for pediatricians who see the case first, especially abroad, where they see the case and then they refer to the pediatric gastroenterologist before they refer for endoscopy. When there is a doubt, when there is no clear symptoms, like there's no blood in the stool, there are no red flag finds, there's no weight loss, no fever, then you look at the clinical symptoms, you do the fecal calprotectin, CRP and albumin will help to select children at low risk. That is, if they have a low fecal cal, you call them low risk, don't send them. And if they are high risk, especially in increased CRP and a low albumin, you send them for endoscopy. So this was the thing of the what and the where of fecal calprotectin, which we all know it's not fecal calprotection, but there is something more in this. And here is the why and the when. So why should we be cautious in interpretation of fecal calprotectin in IBD? Why should we be cautious? Is not what are not all these studies enough? Very simplified, just do fecal calprotectin. If it's more than 50, then you do colonoscopy. There were a lot of pitfalls and lot of drawbacks, and let us now see that. The first is the fecal calprotectin levels are dependent on several factors. This is very, very important. Fecal calprotectin may be elevated in several non-IBD conditions. Very important. Fecal calprotectin does not help in differentiating the different types of IBD or phenotypes. Therefore, a clinical setting should be considered. So let us look at the first, that it varies with age and medication. In young infants, especially in healthy preterm, the value may be as high as a mean value of 98 to 122 microgram per gram. And in full-term newborn, less than 3 months, it can be high as 145 to 277 microgram per gram. So an FC of less than 100 microgram per gram should not be used in children less than 4 years of age. Very important statement. This was published recently in the ISPGHAN position paper. In children more than 4 years of age, can we take more than 50 microgram per gram? Even here, you have to use it with caution, since more than 100 microgram per gram has been seen in healthy children. Medications like NSAIDs, 5-ASA and PPIs can also increase FC. So the level is the most important. If we use just 50 microgram without thinking what is happening, there may be a lot of false positives. Levels do not vary with gender, urbanization, or socio-economic status. Levels vary with collection. Very important. FC concentration is artificially elevated if you collect it from the diaper because of the water absorption. It is also affected by bowel cleansing preparations prior to doing FC levels, and it can be elevated for a few days, minimum 2 or maximum 5 days, and it can be elevated by the presence of blood. This blood can be from non-intestinal inflammation areas like menstruation, anal fissure, hemorrhoids. So one should be very careful when we collect it and ask the parent also whether the sample connected did show macroscopic blood. Then levels also vary with extraction methodology, and this is also very, very important point to remember. And there are several improved and validated ELISA methods have been developed, and there's considerable variability in the extraction methodology in the performance of test kits from the same manufacturer. And it is recommended to use the same extraction methodology. So suppose you send it to one lab who is using one methodology, the same should be used for that patient over time. In Chennai, we are using in the lab, which I'm sending is using this method, the diazoral lysine calprotectin chemiluminescent immunoassay, which they have imported and worked along with a US company. The second point we should know is fecal calprotectin is elevated in non-IPD conditions. Amazing to know the list of conditions where fecal calprotectin is high. A positive fecal calprotectin does not mean that the child has IBD. It is not like that. It's not sine qua non. Infections like bacillus dysentery, viral gastroenteritis, C. diff, malignancies, juvenile polyp, children less than 5 years, we told you, food allergy, untreated, celiac disease, untreated, protein-losing enteropathy, and microscopic colitis can all show elevated fecal calprotectin. So very, very important from the beginning. Do not use just one investigation to make a diagnosis of IBD. So that is why fecal calprotectin is not used for the diagnosis of IBD. I will tell you where it is used for. It only tells you there is intestinal inflammation. And in IBD, what are the pitfalls? It does not differentiate between ulcerative colitis from CD, nor does it help you to differentiate IBD-U from CD-UC. It is in UC, it does not help us to differentiate between pancolitis or left-sided colitis. In isolated proctitis, fecal calprotectin may be normal. In acute severe ulcerative colitis, the absolute level is not associated with prognosis, cannot be used for therapeutic response. In Crohn's disease, it does not differentiate from colonic or small bowel involvement. The diagnostic value is highest in the colonic involvement, but next it can be when the colon and the small bowel are involved. Isolated IC valve involvement or a stricturing disease, FC may be normal, and FC may not correlate whether you have a moderate disease, one value, severe disease, one cutoff is not there. So these are the three areas where FC levels are having drawbacks. One, the variations with different factors. Second, non-IBD conditions associated with elevated fecal calprotectin levels. And even in IBD, there are so many pitfalls. So why should not this cutoff level of 50 microgram per gram be used? Is the most important why. Because though we use it commonly, even for adults, this was used as the cutoff because most of the IBDs have more than 50. However, when there were symptoms of IBS, 28% had more than 50 microgram per gram. This was a pediatric study. But when less than in those with organic disease, only 3% had less than 50 microgram per gram. So cutoff point of 100 microgram per gram rather than 50 microgram per gram has a higher specificity, and this was reported by Olander in 2012, but another person has said 2012 may be a better cutoff. So FC level less than 100 microgram per gram mainly seen in the FGID and the control group. So this is a very good statement made by Van de Wever, who called this the clinical eye, the fecal calprotectin as the clinical eye. If 50 microgram per gram is used as cutoff to screen children for colonoscopy, we can avoid endoscopy in 20%. But if you use 150 gram per gram, we can avoid in up to 27%. So this suggested algorithm for FC at that point of time by Sherwood in 2012, which has been again published in 2021. It is just that when it's less than 50, it probably it is IBS. If it is more than 150, then you think of IBD and you do endoscopy. But if it's between 50 and 150, you look at other things to see whether they are on NSAIDs, look for other causes, repeat it. And if it is less than 50, then you think it's IBS, but it's when it's more than 50, you suggest a colonoscopy. Very simple. But another paper has come out recently in 2021 where they looked at two cohorts of a large number, 2,788. This was done in Switzerland. And here they've said that FCP of less than 600 microgram per gram without matching system suggestive of IBD are unlikely to have IBD. That means for them, their cutoff was more than 600 microgram per gram, which seems to be very high. So I think now we have to come to a balance and use. So here they said finally, when you use a cutoff, you use less than 250. Mainly this is for the primary care and secondary care pediatricians who have to refer. So here they finally said, if the symptoms are there, bleeding PR, and it's not due to constipation, it's a loose stool, then you refer them straight to the pediatric gastroenterologist. If there is doubt, do a fecal calprotectin. It is more than 250 microgram per gram, then you send them for colonoscopy. So when is FC recommended in IBD? We looked into the why. Now we look at the when it is recommended. In diagnosis, suppose you strongly suspect alarm, you do not delay endoscopy for fecal calprotectin. If there are strong alarm symptoms, bleeding PR, weight loss, do not wait for that. But suppose there are symptoms of IBS less than 100 or let you use 150, child is more than 4 years, defer endoscopy. Don't do it. This is not for diagnosis, but it is definitely useful in monitoring disease activity. After you diagnose IBD and you're on treatment, to confirm remission, you can definitely do after the induction phase or after 6 months. Every 6 months you do and watch the fall of FC. If FC, while you are following it up, if it becomes more than 300 microgram per gram, it accurately predicts intestinal inflammation and you may have to repeat colonoscopy or switch therapy or change therapy. You can also use it to check the effectiveness of therapy. So in diagnosis, I told you it is useful only in FGID, in monitoring disease activity, in monitoring effectiveness of therapy. Suppose the child is on infliximab. If you are watching the child and you do a fecal calprotectin after 3 doses, if the fecal calprotectin is still more than 250 microgram per gram, that means there is a risk of relapse within 3 months. Then you also can monitor the post-operative relapses in UC post-colectomy after you do in acute severe ulcerative colitis or in a toxic megacolon. After you do that, to detect pouchitis and inflammation at the anastomotic site, fecal calprotectin is useful. In Crohn's disease, post-intestinal resection, instead of doing repeated colonoscopy, repeated FC measurement will detect early asymptomatic relapse superior to CRP. I'd like to stress again that fecal calprotectin in IBD is usually for monitoring disease activity while on treatment to check the effectiveness of therapy, monitoring post-operative relapses. In the diagnosis, if symptoms of IBS are there, you defer endoscopy, but when strongly suspected alarm symptoms, you need not wait for fecal calprotectin, but please go in for endoscopy. When is FC recommended in IBD? Another new thing, especially in this COVID era, when children, they cannot come. Those who are on treatment, this home by fecal calprotectin kit is now available abroad, and they recommend this to avoid manipulation of stools. And this is a recent paper where the French Society of Digestive Endoscopy recommendations for IBD during the epidemic, and they have been doing that, but it's not yet available in India. When is FC not recommended in IBD? Especially in perianal disease and Crohn's disease, it's no use doing that, but usually because there'll be some infection and it may be high initially and it's not recommended for monitoring. And as I told you, diagnosis of IBD, you don't do fecal calprotectin. You do not use fecal calprotectin as a marker for acute severe colitis. When is FC recommended beyond the diagnosis of IBD? Functional abdominal pain to exclude from organic disease. Very important cause. Unnecessarily, we need not subject them to too many investigations, anesthesia. If there is a doubt, family history of IBD there, the mother is worried, some mucus stool, some light loss of weight, just to do this. In necrotizing enterocolitis, when there is a suspension and the neonate has abdominal distension, serial measurements will help to identify impending NEC. In cystic fibrosis, the occurrence of enteropathy, this has been suggested, but one should be cautious because lung calprotectin is also there. In enox in purpura, to exclude intestinal involvement, especially when there is no bleeding per rectum. When is FC not recommended beyond IBD? There's a long list up to 13. I will just mention some of them: infantile colic, functional constipation, cow's milk protein allergy, celiac disease. Do not do this. Intestinal polyps, in all this, it may be mildly elevated and unnecessarily will be causing more confusion. So in conclusions, ladies and gentlemen, I would like to say fecal calprotectin is still the best non-invasive, simple, child-friendly, sensitive marker in the evaluation of PIBD. Levels vary with extraction techniques, age, medication. In those with non-IBD symptoms, increasing the cutoff level to more than 100 microgram per gram may increase specificity and decrease unwarranted endoscopy. FC can be used in the various steps in monitoring of IBD. FC is also useful in select non-IBD conditions. Home FC is an added advantage during COVID period. And thank you for your patient listening.
Thank you, madam, for the excellent deliberation of this topic on fecal calprotectin.